Hi everyone, and welcome to our module on the lung physical exam. The physical exam of the lung uses a variety of techniques that basically fall into one of three categories. So the first way we examine the lung is through percussion. This is where you place your finger against the thorax in the patient's back and you tap and listen to the sounds. The second way we examine the lungs is with auscultation. So this is using our stethoscope on the thorax, and we usually listen to the upper, mid, and lower lung fields. And then finally, there are a couple of special techniques like fremitus and pectoraliloquy that we'll talk about in this module today. So let's talk about percussion first. When you place your hands on a patient's back and you tap against your fingers, under normal circumstances, you should hear sounds that are described as resonant. And these are sounds that are similar to tapping against an empty barrel. There's mostly air under your fingers inside the thorax, and it produces those hollow sounds like an empty barrel. Abnormal findings to percussion are when the sounds are either dull or hyperresonant. Let's talk about what that means. So dull sounds to percussion are like tapping against a barrel that's full of liquid. The sounds are very different than when it's full of air. And you hear dullness to percussion in patients who have a pleural effusion or consolidation, like from pneumonia. They have some type of fluid filling the lungs beneath your fingers or filling the space around the lungs beneath your fingers, and this makes the sounds dull. Hyperresonant sounds occur when there's air trapped. So they're resonant like normal sounds, but they're just more resonant than usual. These are difficult to detect on actual physical exam. But hyperresonant sounds occur in things like pneumothorax and emphysema. These are all situations where there's extra air inside the rib cage, and that's why you hear hyperresonant sounds. Next, let's talk about auscultation. And this is when you place your stethoscope against the patient's back and listen to them inhale and exhale. And normal breath sounds are described as vesicular, and I have an example of that I'll play for you in a minute. You should know that most all pathologic lung processes result in decreased lung sounds over the affected area. So for example, if they tell you that there are decreased breath sounds over the right upper lobe, they're telling you that there is some type of pathologic process in the right upper lobe. So now I'm going to play for you an example of normal breath sounds, and what you're going to hear is the patient take in a breath and then exhale. Now let's talk about some abnormal breath sounds you can hear when you listen to the lungs. And these are all called adventitious lung sounds. Adventitious means extra or not native, so these are sounds that aren't supposed to be there. And these include things like rales and wheezes and rhonchi, also bronchial breath sounds and stridor, and we're going to talk about all of these right now. So rales are also called crackles, which I think is a better name because it reminds you of what it sounds like. And these happen when small airways pop open after collapse. Usually you hear rales on inspiration because that's when you fill the alveoli and pop them open, but sometimes they can be expiratory as well. And sometimes people will describe them as early inspiratory or late inspiratory or expiratory. And some classic causes of rales that you should know are pulmonary edema. So in patients who have pulmonary edema, they will have rales usually down at the bases because gravity pulls that fluid down towards the bases. Those lungs get wet, and that causes rales to occur when they take in a breath. Pneumonia will cause rales in the affected lobe, and then patients with interstitial fibrosis have all this sticky fibrous tissue that can collapse the airways, and you can hear rales throughout the lung fields. And I have an example of rales that'll play for you now. Those were late inspiratory rales, and hopefully you were able to hear that crackling sound as the lungs popped open at the end of inspiration. Next adventitious lung sound are wheezes, and this happens when air is flowing through a narrowed bronchi. These are usually expiratory as patients try to push air through those narrowed bronchi, but they sometimes are inspiratory and expiratory. And the classic cause here is asthma, so patients who are having an asthma exacerbation will develop wheezing. There are some other causes you should know about. So heart failure sometimes causes asthma. This is called cardiac asthma. It can be a fooler because people will not think it's heart failure because they don't expect the wheezes. Patients with chronic bronchitis can get wheezes, and then very rarely patients who have an obstruction to airflow, like from a tumor, will get a localized wheeze just in one lobe of the lung. If you ever see a question where there's a localized wheeze in the right upper or left upper lobe, this should tip you off that they may be describing a tumor. And I've got an example of wheezes that'll play for you now. Next abnormal lung sound are the rhonchi, and this happens when there are secretions in the large airways, and this causes the breath sounds to sound coarse. And the classic cause of rhonchi is COPD. You will hear them diffusely in the lung fields. in patients who are having a COPD exacerbation. And I've got an example of this to play for you now. Hopefully you can appreciate that those breath sounds were different from the vesicular ones you heard before. They were coarser and harsher, and that's what happens when patients have bronchi. Bronchial breath sounds are high-pitched lung sounds. These sound like air flowing through a hollow tube. Generally, there's a longer expiratory phase than normal in patients with bronchial breath sounds, and the one place that you sometimes see this is in patients who have pneumonia with consolidation. I've got an example of this to play for you now. Hopefully you noticed that the expiratory phase was longer in that example than in the normal example I played for you before. In addition to the expiratory phase being longer, the breath sounds were more hollow, like flow through a tube. It's sometimes hard to identify bronchial breath sounds, but you should at least notice the longer expiratory phase. And the final adventitious lung sound we'll talk about is stridor. This is a wheeze that is almost entirely inspiratory. So recall that most wheezes are expiratory. The patient is trying to exhale through narrowed bronchi, and that gives expiratory wheezes. Stridor is an inspiratory wheeze, which is very unusual. Another very unusual feature of stridor is that it's usually loudest over the neck, and that's because it indicates partial obstruction of the larynx or trachea. And stridor is generally considered a dangerous finding because it often means patients have impending respiratory dysfunction from blockage of their larynx or trachea. So some classic causes are all things that can obstruct the larynx or trachea with inflammation. So laryngotracheitis, which is croup, it's usually a viral infection. It's basically a severe bad cold, usually in a child, that begins to affect the larynx and trachea. And usually it's treated with steroids to knock down the inflammation so that the child's airway doesn't close off. Epiglottitis is very rare in the United States because children are vaccinated for Haemophilus influenza. But if children are not vaccinated for HIB, then they can get this, and they can get epiglottitis, which can cause stridor. If you have an abscess in the retropharynx, this can cause stridor. And then finally, diphtheria causes a membrane of inflamed tissue in the back of the throat, and this can give stridor as well. Next, let's talk about pectoraliloquy. This literally means sounds heard through the chest, and it gets its name because when patients speak, you're not supposed to be able to hear what they say. It's supposed to come through the chest very muted. If it comes through loud and clear, then something is abnormal. So when we say pectoraliloquy, we usually mean that you can hear sounds over the chest through the stethoscope. There are a couple of subtypes of pectoraliloquy. So one is called bronchophony. This is when voice sounds are louder and clearer when you listen to the patient's chest with a stethoscope. Another type of pectoraliloquy is called whispered pectoraliloquy. This is where you have the patient say 99, 99, 99 in a very soft whispered voice. It should come through the stethoscope muffled, but if it's clear, this is abnormal. Another type of pectoraliloquy is called egophony, and this is when you have the patient say E, and it'll come through sounding like an A if something is abnormal in the lungs. All this occurs when you're listening to the lungs through the stethoscope. And all of these abnormal sounds occur when there's fluid in the lungs. Any abnormal pectoraliloquy finding means there's fluid in the lungs. So this is going to occur with pleural effusions and with consolidation from pneumonia. These patients can have all of these things detected on physical exam. Fremitus is where you place your hands on the patient's back and you ask them to say 99. And the vibrations from saying that word 99 are going to travel through the airways to the back, and you're going to detect them with your hands. The amount of vibration that occurs is going to vary with the density of the lung tissue. So if you have a disease where the lung tissue is thickened, you will have increased fremitus. And the only condition where this really happens is with pneumonia. So in pneumonia, that thickened, inflamed lung tissue causes there to be increased fremitus, and over the affected portion of the lung, you will feel the vibrations from 99 more intensely than you feel them elsewhere. Almost all other processes cause there to be less fremitus. So things like pleural effusion, pneumothorax, atelectasis, all these things block the transmission of those vibrations, and they cause decreased fremitus. The final lung physical exam finding I'll discuss is called nail clubbing. So let's take a look at this picture down here at the right over here. If you look at your own nails, assuming that they're normal, you'll see that the nail bed has a gentle downward slope like this. In patients with clubbing, the nail bed loses that downward slope and sort of bulges out and becomes rounded. And this is a picture of it up here on the right. And nail clubbing is associated with many pulmonary diseases. Some of the classic ones to be associated with clubbing are bronchiectasis, cystic fibrosis, which can potentially cause nail clubbing in children, lung tumors, pulmonary fibrosis, and then finally cyanotic congenital heart disease has been associated with nail clubbing. And that concludes our module on the lung physical exam.